Thank you everybody for joining us. We are just going to take a couple of minutes to let people filter through from the waiting room into the main area. So do you just bear with us, please? Okay, I can see those numbers are slowly still ticking up. I think people are still joining us, but just to make sure that we make the best use of our time, I will make a start. Thank you all for being with us here today on such a warm and sunny day. Thank you for choosing to spend some of your lunch break with us today. I'm absolutely delighted to be joined by Dr. Rachel Maciag, who joins us from Oxley's NHS Foundation Trust. She's going to be speaking to us about her research on how professionals and services can help or hinder journeys out of intimate partner abuse. I will hand over in just a couple of minutes, just a bit of housekeeping before we do begin. We are recording today's presentation, and you will receive a copy of the recording and a copy of the slides in the days following today's talk. So do look out for those. You're more than welcome to share the slides and the recording with colleagues or others in your network who you think would have benefited from being here with us today. You can find Rachel's bio appearing in the chat. Please do, as ever, use the chat box to introduce yourself to other colleagues on the call today. And if there's any resources that you would like to share, any links, do please use the chat function for that as well. As always, we have around 20 minutes of time from Rachel speaking through her presentation. We'll then have around 20 minutes for question and answer. Because this is a webinar rather than a meeting, everybody is automatically videos off and muted. So I won't be able to call on people individually to ask their question verbally. If you could therefore please use the Q&A box. You should be able to find this at the bottom of your screen. If you see where the three dots are with the more label, the Q&A tab can be just found by clicking on more. If you could use that, please, to post your question, that will come through to me, and then I will be able to put the questions to Rachel in the Q&A session towards the end. So just to reiterate for people who are just joining the call, everybody will receive the recording, everybody will receive the slides, and if you could use the chat box for intros and resources and the Q&A box for questions that you would like Rachel to reflect on and discuss towards the end of today's talk. I won't take up any more of your time, Rachel. I want to make sure you have your full 20 minutes. So over to you. Thank you again so much for joining us. We're delighted to have you for our VAMHN webinar.
Thanks, Shan. Thanks everyone for joining to come listen to about my research. So I'm going to be presenting my thesis, which, as you can see the title, and I guess just a very brief kind of background as to why I did this research. It's to kind of think about the mental health needs of victim survivors and thinking about access to long-term psychological treatment. At the moment, safety and stability is often required for long-term therapy, but this is really challenging when there's ongoing intimate partner abuse, and there may be psychological mechanisms that make it difficult to leave an abusive relationship. So really this was kind of thinking about that more with the idea to consider those mental health needs and psychological support. So yeah, that the study is looking at the role of therapy, the role of professionals and services in what's helpful, what's not helpful in journeys out of intimate partner abuse, and it's a modified grounded theory using a social constructionist approach. And I interviewed 9 participants, concurrently analysing data and recruiting whilst developing a theoretical model. So my research questions sort of relate to thinking about what help and hinders the journeys of victim survivors out of domestic abuse, and what the psychological needs are of survivor victims during and after ongoing abuse, and thinking about what barriers and issues victim survivors face in escaping relationships and how that relates to professional contact. So in terms of who took part, I had there's quite a mixed range of different experiences, backgrounds. There were limitations in terms of sort of ethnicity, but I think one of the real sort of strengths of the participants that took part was that there was a huge range of different service input and journeys, from some receiving absolutely very little support from professionals to quite extensive support. And as you can see at the sort of second to the bottom, quite a wide range of different services were utilised and discussed as part of this research. So I'm going to go straight into the findings. So one of the sort of overall key findings is the concept of validation. So feeling heard and believed, affecting victim survivors' trajectories out of intimate partner abuse. And what I'll go on to talk a little bit more about is how those interactions, that validation or invalidation, can lead victim survivors to become either more entrapped in an abusive relationship or move towards recovery and safety. And I'm going to share my model that I developed for this to explain this, which talks about 3 phases of entrapment, turning point, and recovery. And overall, the journeys, or patient is supposed to be on that slide. The journeys that are presented are cyclical and non-linear, so they sort of move around this model that's being presented. But I will be presenting it in quite a structured way, just to help with sort of understanding. This is my model. I am going to return to this at the end, so please don't worry too much about taking this all in. But if you're someone like me that's a bit visual, you might appreciate seeing it in just before I go through the results a little bit more. But kind of going through the phases are that journey of entrapment. So being in an intimate partner abuse, and the turning point, which is when contact with professionals or services most often happens, and then moving into recovery. But as I say, this is fluid and adaptive, and there's reoccurring cycles that take place across this model, going back and forth. I guess as well, in line with it being grounded theory, one of the emerging themes was around coercive control, and that particularly is focused in that entrapment phase. And I'll speak a little bit more around that. But yeah, and I'll think about sort of short and long-term needs, and the wider socio-cultural context that surrounds that ongoing domestic abuse through to being able to leave and being able to recover from that. I'm going to move through these slides fairly quickly, but kind of going into more around that phase of entrapment. This is when that coercive control creates pervasive fear, confusion, and unpredictability. And this is where that manipulation and coercion gradually leads to the loss of the sense of self, and often perpetuated by entrapment and other socio-cultural factors. I'm going to go through the subcategories through my quotes in a short while. But within that entrapment is the process, is a category of internal struggles and awakening. So this is the process of internal conflict, realizing and beginning to sort of, that can lead to change, but a bit of an internal battle. So the next sort of phase in that model is around turning point. So this is when often there is contact with services or professionals, whether that's direct or indirect or through choice. But this is often an opportunity or a little bit of a window when victim survivors might receive or seek out help. And this is what I'll go through is sort of how it relates to critical incidences. So these are moments when There may be internal turmoil and awakening, but these can be gradual or sudden or cyclical, and I'll speak through these in a little bit more. But within this phase, there is the role of an external input, external validation from the other. So following that, there's the recovery and rebuilding phase. So this is often when they may have left the abusive relationship. That's not to say that there isn't ongoing abuse, but typically that's when, you know, there has been either practical change or psychological change. But within this phase, I will talk a lot about the psychological costs that come through being in this period and how difficult actually it can be even after that relationship's been left. And I'll also sort of be talking a little bit more about the short and long-term needs, both psychological and practical, that change from entrapment all the way to recovery in a very sort of unique way to that person's individual journey and also their social circumstances. And a cross-cutting phase across all of those, a cross-cutting part is across all those different phases where the sociocultural context was a finding that really sort of emerged in terms of both sort of socioeconomic sort of context and what sort of resources are available to victim survivors. But within this sort of category, I'll also speak a little bit about other forms of external input that had influence on those trajectories as well. So I'm going to go through some of the quotes now and go in a little bit more deeper into kind of what I've spoken about so far. So thinking about that entrapment, that phase one, very much in that coercive control, experiencing coercive abuse and other forms of abuse, and within that intimate relationship, there's the loss of the sense of self. So within this is the sort of entrapment, the coercive control, and this is that cumulative impact of daily control and manipulation that caused the participants, victim survivors, to question their own judgment and live in a sense of unreality. And within this place is often internalizing those experiences, often as something being wrong with them, and that's exploited and reinforced by perpetrators. Also within the findings was how manipulation is often reinforced by socioeconomic constraints, so financial capital, immigration status, which deepen that entrapment more. So often the participants spoke about that, you know, being within that loss of the sense of self, and some of the things that started contributing to small or large shifts or changes psychologically or emotionally or behaviorally were the critical incidences. So these were often either particular big moments or accumulation of other incidences that led to the opportunity for turning points, and the potential for seeking out service, support or advice, things like that. So these critical incidences could lead to small or big shifts cognitively, emotionally or behaviorally, which could gradually increase to thinking about leaving or taking those steps, or there may have been sort of major things that happened. And yeah, these lead to sort of seeking out help or receiving help. And I guess some examples of what those critical incidences included sort of physical abuse, particularly when there was more of a coercive control element before that, which, as we know, is quite insidious and quite pervasive and entraps into that loss of the sense of self. So a physical abuse incident happening, noticing lies, cheating, having mental health breakdowns, suicidality, and also physical sickness, so getting infections as a result of such high levels of stress. And again, these are sort of non-linear, they move back and forth, and there was a bit of a process and very unique to the individual circumstances of that person. And within that process, there's the reappraising and naming of abuse. So this is often that sort of developing a bit of a language to describe that abuse, to be able to name it in a separate way than what may have been internalized or what may have been abusive, manipulative tactics. And that language allowed an alternative explanation for what was going on. And this often was quite a gradual process. But this came from external inputs, often sort of therapy or professional. Social media was quite a big one, and friends as well. So I guess just really raised the importance of that external influence having quite a big influence, really. So within this period, there was a lot of awareness building, identity reconstruction, but also early acts of resistance and change taking place. But also to note that this was a really key time that vulnerability of victims increased as well, as perpetrator tactics also increased. And as you can see, this took place during that internal struggles and awakening. So yeah, hopefully getting a bit of a picture of what that looks like. So within this, that sort of entrapment phase, there was survival and parallel living. So this was, and particularly for participants who left more gradually, it wasn't so sudden. There was a process of living with them and being aware of abuse, but still being married or having to continue. It was described by one participant as having to play the part still. So within this phase, there was resistance to abuse and survival processes being enacted whilst continuing to live with a perpetrator. And this kind of looked like maintaining outward compliance whilst internally detaching. And often navigating what were escalating manipulation and entrapment from the perpetrator. So some of this looked like testing realities, so starting to see things that weren't quite right and doing things to test that out and check their understanding, check the the challenging really the sort of coercive control and that type of abuse and narrative, but gathering evidence to do this, and also having to suppress emotionally, which was quite damaging in the long term in terms of mental health needs. But also planning and abuse was sort of taking place, and challenging abuse, which could result in physical abuse escalating as well. Also within this stage, there was building power resources. This looked very different depending on the victim survivor, but often practical needs were taking priority, and very dependent on what that route to safety was. So was it legal, was it police, or was it, doing things in a different way? And that was what, was quite interesting to hear how diverse that was. But it often looked like seeking social connection through employment, through social circles, and gaining financial capital, so saving money. But that also was for some people that were able to afford a solicitor, for other people that wasn't an option. So really seeing how those decision makings were influenced by what power is available. And also there were intersecting needs. So mental health, meaning someone's not well enough to go to work, or having childcare or children with additional needs. So going into the kind of second stage, the second phase in thinking about the role of external validation. So professionals were seen as objective, unbiased, and a fresh pair of ears or eyes. And those perspectives really carried weight in that sense making. And participants described as being a bit different to friends or family, whose views they might question their validity a little bit more, thinking, saying that they're looking out the best interest, they don't understand him, and do it that process can kind of take place. So that professional, seen as an objective view with the professional lens really carried a lot of weight. And this leads to sort of my core finding around validation or invalidation. So validating responses gave clarity, safety, and supported movement towards leaving or considering leaving, hope and empowerment. So examples of this were feeling believed and understood, professionals expressing anger or disgust at what they've heard, legal professionals taking the case seriously, professionals naming abuse on behalf of the victim and escalating concerns, and being given support and help, feeling listened to, and having someone hold strength for them when they felt they didn't have that strength at that time themselves. And this could help with gradual empowerment, and participants often described later on being able to have a bit more strength to manage some of the things that felt really difficult earlier on in the stages or in the phases. And in contrast, invalidating responses deepened self-doubt and entrapment, and they perpetuated that loss of the self. So examples of this was disbelief or minimization, particularly in thinking about coercive control, and those sort of less visible forms of abuse. rigid procedures, particularly in the criminal justice system and police. And in fact, for some participants, this led to delays in leaving and questioning whether the abuser was right in what they were saying, and thinking that maybe it isn't bad what was happening. And for some, this increased that they remained in those relationships longer and had greater mental health distress, including suicidality. So within this, there were missed opportunities. So these were various different ways that abuse was overlooked, particularly coercive control. And often that, that was GP visits, couples therapy, police, mental health professionals. And important to note that there was mental health overshadowing, where psychosis, one of the participants with psychosis, the domestic abuse was overlooked because the psychosis was the thing that was kind of being focused on. And as a result of missed opportunities, 2 participants had additional pregnancies and remained in that relationship for years longer. So barriers to disclosure, the coercive control, feeling confused, feeling they won't be believed, that narrative, or maybe not, it's not that bad, and fear of disclosing suicidality and domestic violence, particularly in concerns that their children would be removed, and also navigating abuser threats that and previous experiences where they will be feared that they'll be made to look kind of crazy or a bad parent, and that manipulation being a barrier in itself. So helpful and unhelpful support, so feeling understood, being informed of options that are available, so things like contact centres, non-molestation orders, and having accessible help was really crucial. And often those I spoke with was sort out the empowerment initially and those practical support and wanting that abuse condemned by a professional. But some unhelpful things was sort of invalidating comments that, inferred that it's hard to believe that this kind of happened, minimizing abuse and not recognizing the non-physical elements of that abuse. And just to kind of comment around the importance of readiness, participants did sort of describe about needing to feel ready to accept help. However, there were seeds that could be planted from these interactions. So in terms of the psychological growth, there was a huge burden to leaving. There was emotional and psychological toll to leaving that relationship and having to balance those mental health struggles and the practical challenges of rebuilding, particularly as abuse often intensified amid or abuse-related distress or trauma intensified with ongoing stresses like court trials, etc. And to kind of say that there were a huge amount of mental health needs that came up across these interviews, and they changed across the journeys, but throughout all the journeys there was always a mental health need there. So some examples were sort of low self-esteem, PTSD type symptoms, but also being really mindful of how that overlaps with survival strategies, depression, dissociation, worrying and relational difficulties, and a real need for individual formulation of difficulties and person-centered care. So there were structural barriers to therapies. No, very, very few of my participants actually accessed any support, psychological support that was most helpful, often seeking out workplace counselling. And if there was capital, private, but within the NHS, there was very little that felt was offered that suited their needs. And throughout this process, there was post-traumatic growth, and these that was quite protective and could empower to move forward and help to reduce psychological harm. So doing things that were previously forbidden, setting boundaries, maintaining relational safety. But it's important to note around the impact of the CPS and the prosecution service, and waiting for an outcome of a court trial left people in limbo, and they felt they couldn't recover or move on until they had resolution. And that was very tentative on the outcome of that as well, and how that would impact them long term. And then finally, in the socio-cultural context, there was an awareness through the media. So external input that really referenced their perceptions of abuse, and that often led to seeking out help. So some examples was how coercive control was portrayed in a soap, homicides in the media, making the victim survivors recognize that they felt really unsafe actually, and this could get quite bad quite quickly, and that led to seeking out support for some for help. And the quote on the screen is around those posters, being forced to sort of not be able to deny a situation any longer. And in terms of the CPS, yeah, I've sort of mentioned about how that process can prolong and extend that recovery process, and it can cause active harm if it doesn't go as hoped. And the process of evidence collecting in itself was experienced as quite validating or invalidating potentially. So going back to that kind of model, hopefully it makes little sense. I'm mindful of time, so I'm not going to go on it too long, but hopefully it presents a little bit, and you'll get the slides later to kind of look at this a little bit more. So yeah, the strengths are that there was a diverse range of journeys. So it was really interesting to see, yeah, the similarities or differences and that process, but there wasn't a full representation of women of all ethnicities or religious communities. And this was limited to women who have escaped abuse. So the implications are that early intervention in responding to disclosures and creating opportunities to engage mental health support is really important when there's ongoing abuse of coercive control. And there's a need for more research in psychological and mental health interventions for distress in the context of IPV and coercive control. And health services need to improve their identification, response and intervention to ongoing IPV and collaborative working with other services. And wider sociocultural influences can influence help-seeking behaviour, and there may be benefits to expanding efforts. So thinking about the other ways that external input could be helped, for example, addressing the fears of child removal. And more research needed in diverse cultural backgrounds and marginalised communities. I imagine there would be differences, potentially. And victim survivors have ongoing evolving needs from entrapment through to recovery and requiring a flexible, person-centred support for various stages. So yeah, in summary, the validation and validation of reality by a professional can be a pivot point in determining if victim survivors remain trapped or move towards recovery. And there are changing short and long-term psychological and practical needs across all three phases. And journeys are cyclical and non-linear, requiring person-centered approaches and responses that validate and empower. And survivor victims may present with a range of mental health experiences and psychological distress that require support. And these needs are continuous and evolving. And yeah, I've just got some final quotes there, but I've gone over slightly.
Thank you, Rachel. Let's maybe leave that slide up so people have a chance to read it before we bring the slides down. Flavia, please. Thank you so much for such a comprehensive presentation, a really clear presentation with a lot of really important findings in there. Just a reminder to everybody, if you have questions that you would like to put to Rachel, they should go into the Q&A box, please. I'm then able to read them and put them to Rachel. I can see some questions coming through, which is great, and we'll get through as many as we can. So Rachel, your findings position validation as a potential pivot point in survivor trajectories. Could you just tell us a little bit about what you think validation looks like in practice in brief or routine clinical encounters, especially in overstretched services?
Yeah, that's a really good question. I think it's going to look quite differently within services. I think my mind goes to thinking about the infrastructure, for a start. And I think, coming from a health services perspective, things like domestic abuse aren't, it's not something that's commissioned within the sort of as a health need, although I'd argue it is a public health need. And although I think we're getting better, and I know in Oxley's we do a lot of work around domestic abuse and thinking about those mental health needs, which is so needed and important. I guess the challenge is around thinking particularly around coercive control, how pervasive and hard it is to spot. And so and thinking of different health services coming into contact with victim survivors across that journey, where they may not explicitly be saying there's domestic abuse, it might not be able to recognize that yet. It's really challenging to to be able to sort of intercept. However, I think there is a sort of need for that training to become more readily available, or for different services, because we know health services are most likely to get disclosures or to have that contact, to be having, thinking about our responses essentially to disclosures or the options for that. So, that might look like sort of how that's assessed for, how that's checked in for, and professionals feeling confident and being able to have these discussions, because it is really challenging, and things aren't. It's a very complex. It's a very complex clinical need. And so, yeah, particularly in thinking like physical health services as well, where it can be really challenging to respond or be able to spot it. So, yeah, it's a bit of a waffle in terms of the answer, but I think there's something about the infrastructure and how we respond, and making space for domestic abuse to be considered within health services, and then thinking about pathways in services as well that allow for that, and training staff confidence and having those conversations, interagency working, that kind of thing.
Thank you. So it's kind of a following on question. So you talked about cases in which mental health presentations had overshadowed coercive control. I wonder if you could talk a little bit about what practical changes you think might help mental health professionals better distinguish trauma responses, survival strategies, coercive control from symptoms that are kind of located solely within the individual.
Yeah, and again, I think it's so complex and challenging. I mean, the standout from just the participants I spoke with is that it wasn't asked for a start, it wasn't spotted, and I think there was a quote in my write-up around how, that's why coercive control is so it's so hard to spot, it's so pervasive, it's so insidious that the victims that I interviewed weren't aware that it was happening. Professionals didn't spot it. And then, as one other participant said, each time an abusive incident happened, their psychosis got worse, and that ends up being the thing that's spotted. I mean, in terms of kind of thinking about that, I think it comes down to the importance of really formulating what's going on for that person and taking the time to do a full psychological assessment around what is going on in that person's life, what are their relationships like, and being able to spot if there are concerns around what's happening in that relationship dynamic, or and again, then with that in mind, if there are sort of survival strategies, I imagine it's not going to be a clear-cut kind of separation necessary of symptoms and survival strategies. They are going to be interlinked to a degree, but the importance of that person-centered care and working with the person to keep themselves safe, and victims know the perpetrator kind of the best, and thinking about that their needs within what's going on, and not invalidating those survival bits and walking alongside them.
Yeah, thank you. And just really, it's always lovely when the questions follow on nicely from one another. So thinking about the kind of the need for person-centered care, you talked about how kind of rigid or manualized approaches could feel invalidating for some survivors. So how do you think we can balance the realities of what are often quite protocol-driven NHS services with that need for flexible person-centered responses?
Yeah, it's a really good question. I think the difficulty with complex cases is the response to providing person-centered care. It's that difficulty of service barriers, service provisions. We know about the gaps in services and how that victim survivors need to choose between different forms of support. And again, I think it does still come down to the importance of a really solid formulation, having key professionals that can build that relationship, and sorry, I had like a side thought, but yeah, being able to work alongside that person, particularly if they're not ready to leave, or and finding ways to meet their needs. I've lost my thought that came to me now. I was thinking about risk assessments as well, and how, particularly with intimate partner abuse, quite rightly, we have to think about risk. It's so important, but we know that it can be quite an anxiety provoking thing to we don't want harm being caused to people, and I think that can take a real focus around it, and the emphasis on leaving an abusive relationship, which of course it makes complete sense. We don't want people to be in relationships that are toxic or unhealthy. However, again, in that person-centered way, really understanding what's going on for someone that they can't leave at this moment, or what might be going on, and then really providing support and interventions that work with mental health needs, which we know, and I can talk a little bit more if it's helpful, around what those mental health needs are when someone is still in entrapment and still receiving support.
Yeah.
So it's not a barrier to receiving help, if that makes sense.
Yeah, very, very glad to have a couple of minutes from you on that. So do expand on that if you're happy to.
Yeah. So I think there's some, when we think about particularly long-term psychological interventions, I think the brain kind of tends to think about trauma-focused work and working with PTSD. And I guess that what the research is starting to grow in terms of ongoing abuse, that's not necessarily the thing that's indicated, particularly if someone is still within that context. However, thinking about what relational processes are taking place that is contributing to that entrapment, what apart from things holding in mind attachment and things like that, and there is some research around the needs of the unmet needs of women who remain. And they're quite holistic, they're thinking about their social inclusion, resource building, reconnecting, and supporting with things like, emotional regulation or distress. Dissociative symptoms, I think, is a really important one that we need to be considering more, particularly with ongoing abuse, because that is connected to a survival strategy as well. But being really mindful that, victims who are in ongoing abusive relationships are dealing with a huge amount of chronic stress and having to manage their safety constantly. So, working in a trauma-informed way to support those ongoing needs. So yeah, it's really moving from not just thinking about PTSD and trauma in the sense of the events past, but more thinking about what are those unmet needs that are continuing to be there, and how can we get quite creative really in managing that, and that the importance of interagency working to manage risk and any changes or shifts, because we know that risk does increase when victims are thinking of leaving or have left. So yeah, the real importance of those pathways in mental health services and interagency working with other specialist services, and you're really working with in a formulation driven way to meet the needs of victim survivors in ongoing abuse and who are experiencing coercive control.
Thank you. It's really helpful. And how, I suppose it's following on a little bit from an earlier question around the kind of the balancing, the kind of the manualized approach with the need for person-centered therapies. But how can clinicians work therapeutically with survivors when they know their service has a limit on the number of session numbers that you can offer, and that's insufficient to meet the presenting needs?
Yeah, it's a really good question. I'm not sure I have a hard and fast answer for that. It feels quite a big, wider issue, and NHS provisions more widely. And I mean, I'm always of the view that I think we almost do ourselves a misjustice by sometimes not offering the adequate amount of support, because then we're not quite necessarily always meeting that need, and it could lead to I don't know if a half-done job is the right word of saying it, but not giving someone the adequate things that they need. So I feel like this sort of relates to that socio-culture and economic kind of considerations within that. But the fact of the matter is that we do work within limited services. But I think, I mean, in terms of kind of, I guess, working therapeutically, I think there are still so many options, and there are doing things sort of, again, integratively with other services. But the importance of, what would that survivor's goal be? We might not be able to do everything, or meet all those needs. However, what things in this present moment are going to be most useful for that person within the limitations that are available, and that is then, working collaboratively. That process in itself can help, people to think about their needs, and that might lead to change later on down the line, or accessing different types of services. So I guess it's just being quite creative in using what resources are available, making making what limited provisions as specific and helpful as possible. For example, some of the participants I spoke with, it wasn't necessarily working with the domestic abuse. It was managing the worry that came with criminal justice service processes. It might be just a specific part that's creating the most difficult, and it's not the most ideal thing to be able, you want to be able to do as much as you can, but within those limitations, what's the best way that we can.
Recognizing those limitations and prioritizing with the survivor within the context of that. Thank you. So we normally focus very much on the kind of the implications of the findings, but just I think we have time for a kind of more academic or theoretical question. So could you give some more details on who else's work you've drawn upon in developing your findings in terms of both survivors' practical and emotional journeys? So I think if people were wanting to do some of this kind of reading themselves, which authors or theories or frameworks would you be pointing people towards?
Yeah, thank you. I mean, this is the limit with my dyslexia. I'm really bad at remembering names, so I'm going to go to my references just to help support me with this. But yeah, I think a lot of the thinking around entrapment, particularly the work of sort of Ptolemy and sort of Williamson, were really helpful, I think, in conceptualizing that kind of the social and systemic elements. And I quite like sort of using the work of Crump as well. So this will come out with the sort of slides. I probably have got more, but I'm so bad at remembering sort of names and titles. But I guess something that when I was doing the sort of the research and background reading around this, and I guess coming from a social constructionist approach, is how the sort of legal changes around domestic abuse in general and how intimate partner violence and coercive control has been conceptualized over time. We are quite behind the times, actually, in terms of how we, understand the needs, and that it's hard to separate that from the sort of wider social context around that. So some of them were quite sort of older models, and that was with my model was building off things like the barriers model, or the earlier sort of looking at why victims may find it really hard to leave those relationships. So yeah, sorry, it's not a clear response. I'm really bad at remembering things.
No, not at all. It's really useful to have the reference list, and everybody will get that with the slides, which will have those kind of key readings and references there. So thank you. I'm going to draw us to a close. We have just a couple of minutes left. So Rachel, thank you once again for providing today's talk. It's been absolutely super, so informative, really practical. So thank you. Everybody, thank you for joining us today. You will receive the slides and the recording in the coming days. If you're new to the network, the Violence, Abuse and Mental Health Network, maybe you got the link from a colleague or you saw it on reposted on our social media, please do consider joining the Violence, Abuse and Mental Health Network. It's free to join, and you can join at the link that I've just pasted into the chat. That gives you access to our expert and network directories to identify collaborators and find expertise, build partnerships. It also gives you our monthly evidence practice briefings. These are curated monthly updates on research policy and practice developments. You get early access to tools. You get direct invitations to these member learning sessions and lots more besides. So if you're not already a member, please do join us online, and you can also find us on LinkedIn, where we share lots of relevant opportunities and news and analyses. So thank you very much. We will not be having a webinar in June, but look out for the next one, which should be coming to you in July and August. Thank you. Enjoy the rest of your day. Have a good week. And thank you once again to our speaker, Rachel Maciag.
Thank you, everyone.